There's a lot of misconception about the subarachnoid hemorrhage. Subarachnoid hemorrhage can really be rapidly fatal. I actually pronounced a person dead today, an hour ago, before we started filming this, of a subarachnoid hemorrhage. It was huge. It created a person effectively brain dead over a few hours. And what the family could not get over is that they couldn't get over that he was sort of a clean living guy with no medical problems. No high blood pressure, no diabetes, not a guy who smoked. And so it's like, how can that be? There had to have been a precipitating thing, and there doesn't have to be. It can just happen. Now, sometimes when you talk to people about subarachnoid, somebody says the most common cause of a subarachnoid hemorrhage is trauma. But when we talk about a subarachnoid hemorrhage as blood through the subarachnoid system, it's not really the kind that's from trauma. In other words, if you have a gunshot wound to the head or a stab, yeah, there's blood in the subarachnoid space, but it's not what we mean by a subarachnoid hemorrhage. Subarachnoid hemorrhage is a rupture of the circle of Willis. And a spontaneous rupture. And is it caused by hypertension, diabetes, hyperlipidemia? Is it caused by being obese? Not really. Unfortunately, it just happens in people, and the aneurysm just gives out. So what happens is that these aneurysms, 1 in every 50 people, that's enormous. And when they pop, they looks like the sudden onset of meningitis. Fever, headache, stiff neck, photophobia, Kernig's and Brzezinski's, although I can never remember which is which, because it doesn't matter. It's blood irritates meninges. Meninges is a $5 word for covering of the brain. The same way blood of a ruptured ectopic pregnancy causes tremendous abdominal pain. And blood is irritating. Blood or clots or collection of blood can cause a fever. Subarachnoid gives a fever, meningitis gives fever. Headache, stiff neck, photophobia, because blood is irritating. People with GI bleeding, melena. People with GI bleeds have diarrhea because blood is irritating. All vampires have diarrhea. So how will you tell that apart from meningitis? One is that meningitis doesn't cause a loss of consciousness. You get a loss of consciousness because the bleeding causes a sudden increase in intracranial pressure. And if you have this sudden increase in intracranial pressure, you can't perfuse your brain and you pass out. Logical. You wake up most of the time. Now, focal neurologic findings can happen in subarachnoid, but then again, most people don't realize that meningitis can give focal neurologic findings too. What's the most common in meningitis? Cranial nerve defects, most commonly deafness. But focal findings, why? Because when that blood vessel ruptures, when the aneurysm ruptures, a high pressure jet of blood cuts neurologic tissue and severs the neurons, and you have focal findings. So how will it differ? 1, the loss of consciousness. Number 2, it's sudden in onset. It's very sudden. People don't get meningitis like this. I was walking down, I felt all of a sudden, then I went, It doesn't happen that quickly with meningitis. It happens, even acute bacterial meningitis doesn't happen in minutes, seconds, but subarachnoid do. And that's how you tell it apart. Very sudden loss of consciousness. So the reason why this is also important is that it helps you to understand the diagnostic test. For instance, in meningitis, you don't have to do a CT before the lumbar puncture. You don't have to do a CT unless there's focal findings, altered mental status, loss of consciousness, or papilledema. So in a person who's got meningitis, you don't have to do a lumbar puncture, CT before the LP unless you have focal findings, altered mental status, papilledema. But in subarachnoid hemorrhage, it's always a head CT first. Now, I'm going to ask you a question, and most people are going to be wrong. Now, one of the things I can't do for you in a video that we can do in live class is write out the wrong answer before you say it. If I asked you why we don't do the lumbar puncture first, because the lumbar puncture will show blood in subarachnoid. Why? The most common wrong answer is people saying, because people will herniate. They'll herniate and move their brain. That's wrong. You don't herniate with a subarachnoid because there's no difference in pressure between one side of the brain and the other. To herniate, you have to have a mass lesion or a collection of blood, something that will shove the brain over. And that's not what happens here. You don't need to do the lumbar puncture first, and you don't do the lumbar puncture first because you don't have to. The CT scan shows 19 out of 20 people. Now, the most accurate is an LP, but you only do it for the people who are the 5% false negatives. The LP will show xanthochromia. What's xanthochromia? It's a $5 word to say red cell breakdown yellow. I got pee-pee in my brain. Because there's the same way that when you have hemolysis, haptoglobin goes down because you're recycling your hemoglobin, and that's what you see in the lumbar puncture. The most important one that you see right away is just simply a lot of red cells. So let's do this again. Why not do the lumbar puncture first? It's not because you herniate. You don't herniate from a subarachnoid. You herniate when there's a difference in pressure between one side of the brain and the other. And you go, what's that on your rectal exam? Is that my prostate? No, it's not your prostate, it's your pons. So you have to do a CT scan before an LP when you have focal findings in papilledema because you might herniate. Here, why bother? What would you like? A steel split needle in your spine or contrast negative CT? The LP is if you have a false negative. Why false negative? Sudden onset of meningitis with loss of consciousness. It looks like a subarachnoid, but the CT is negative. Do the LP. Well, also, why might the CT scan be falsely negative? The CT scan might be falsely negative because of two things. Number one, a very small amount of blood. Number two, if you're doing the LP the day or two later. The CT a day or two later. If you do the CT on day one, it's 95% sensitive. But if you do the CT on day 2, 3, 4, you lose, the CT loses about 5% sensitivity every day. A normal ratio for every one white cell, there should normally be about, how many red cells? For every one white cell, there should normally be about 500 red cells or 1,000. For every one white cell, there should be 500 to 1,000 red cells. If there's more white cells than that ratio, you have an infection. So let's do that again because it's the very essence of the questions. You have a person that has fever, headache, stiff neck, photophobia, and it looks a lot like meningitis. It is very easy to mistake it for meningitis. You do the lumbar puncture. The lumbar puncture shows increased white cells. Gee, is it meningitis or is it just blood? What's the ratio? This is blood in the subarachnoid space. Yeah, it disseminates throughout the whole thing. So you'll see blood, and that's why it's contrast negative, because blood, that's just showing you where it ruptured. Everything that you see white there is blood in subarachnoid space. Why not just go straight to the lumbar puncture? Because you don't have to. Would you rather have a nice contrast negative CT with a 95% sensitivity? Or do you want a 4-inch steel needle going in your spine with somebody who's just finished medical school 15 minutes ago? Hey man, I'm going to do your lumbar puncture. Does it go in the front or the back? I don't know. Maybe we'll do it in the front. If I do it in the front, I can get a stool sample of blood gas through your aorta and eventually hit your spine. Or would you rather have this? You'd rather have this. So the EKG, we don't know why. We think it's because of big, huge sympathetic discharge. Remember Takotsubo cardiomyopathy in cardiology? Suddenly emotional, and you get dysfunction of the heart. Well, there's a connection between our brain and our heart. Who thought? And we think, big sympathetic discharge, but your point about knowing is you can get very distinct T-wave abnormalities, big ones, that actually look like you're having ischemia, cerebral T-waves, and you may not know whether they're ischemic or not until you have to have the troponins or a stress test. So the angiogram in a subarachnoid, because what treats a subarachnoid? Well, you got a broken blood vessel. There's nothing really that reverses it. You bled. So why do you do why do you do the angiogram? The angiogram can't get the blood out. In other words, you can't go reverse the blood that's in the brain. The angiogram is to prevent it from recurring. So you prevent it from recurring by getting up there and embolizing it or coiling it, put some platinum wire in there and stuff up the hole. And so the angiography tells you where to fix it. But isn't that the same for all angiograms? I don't need to do a cardiac angiogram to know you got coronary disease, I can stress you. I do a cardiac coronary angiogram to say where to fix, angioplasty or bypass. I don't need an angiogram to tell me you got peripheral arterial disease. You have claudication, ankle brachial index. I do the angiogram to tell me where to fix. And that's that way with blood vessels all over the place. So the angiogram is to determine where to fix so that you know where to coil it or embolize it up so it doesn't recur. Because half of people who recur will die. You diagnose the subarachnoid mostly on CT, sometimes LP, but the only way to be able to tell which vessel is an angiogram of some kind, and doing an angiogram with a catheter not needed too much. Also, angiograms with catheters can have side effects such as death and stroke. So contrast on CT and MRI is to detect mass lesions like cancer or an abscess. You don't need contrast. Contrast is not when looking for blood, not just intracranial hemorrhage, but subdural, epidural, subarachnoid hemorrhage, no contrast. So you're going to go there and do the angiogram to know where to coil it up and embolize it. And you notice I'm judiciously avoiding the word clipping, because clipping an aneurysm implies neurosurgery. It implies cracking open someone's skull. The clipping it implies that you've cracked open someone's skull so that you can see the location of the vessel to repair it, and that's not the first choice in a subarachnoid. You're not doing the clipping because it's got more complications for no better outcomes, coiling and embolizing it. So what's the point of the calcium blocker? When you bleed, all blood vessels that rupture have a tendency to want to spasm, to constrict the muscular layers to decrease the blood flow. So it is true with the subarachnoid. Now, what we've noticed and what we know is that that spasm causes strokes or is associated with stroke later on. So we use a calcium blocker to prevent subsequent ischemic stroke. And sometimes people say, well, won't that perpetuate the bleeding because you're preventing the vasospasm? And the answer is no. The bleeding has already stopped from that episode on its own because it's basically, like any blood vessel, clots itself off, preventing subsequent stroke. You coil it up to prevent a repeated hemorrhage because half of people who rebleed will die. Now, so choroid plexus in the brain makes cerebrospinal fluid, carbonic anhydrase. That's why we can use acetazolamide for pseudotumor cerebri. And where does it drain out though? Choroid plexus makes it, but where does cerebrospinal fluid drain? Well, it drains out of subarachnoid granulations. Is the toilet, is the drain, is the bathtub drain. And so these subarachnoid granulations can get clogged up with blood cells. And if your subarachnoid clogs up those subarachnoid granulations and you get hydrocephalus, then we shunt you to prevent you getting hydrocephalus because the subarachnoid granulations get clogged up with red cells to prevent it, or if it's already occurred, you have to bypass the subarachnoid. It's kind of like your hair in a bathtub drain. Woman is in the emergency department with severe headache 1 day prior to admission, fever, stiff neck, photophobia. Well, that's meningitis. No, it could be subarachnoid. No, it's meningitis, subarachnoid. Well, how do we know whether it's meningitis or subarachnoid? Look at all those white cells. Anything above 10 white cells is abnormal. But look at the red cells. So there's 1,200 white cells, 50,000 reds. So you remember the ratio? 1 white cell for 1,000 reds. So that means 50,000 red cells only entitles her, she should have no more than 50 white cells. Okay, Fish, you said 1 white cell for every 500 to 1,000 red cells. Okay, but even then, it's 50 to 100 white cells, and this is 1,200. So that means that for this person, that makes this meningitis. It's meningitis because the number of white cells is many more than is expected by that number of red cells. One white cell for every 50 to 100 red cells. So that means, 1 to 1,000, 50 white cells, 1 to 500, 100 white cells, no more. Angiogram is to tell the location of a bleed so you can repair it. Nimodipine prevents strokes. Embolization, or putting a platinum wire in there, prevents the rebleeding of it. Surgical clipping has the same efficacy. You just got to chop through my skull. I don't really want that. Thank you very much. Reading in contrast with CT is not for blood. Contrast is for cancers and infections. Don't consult people. Just do your own thing. Cerebral vein thrombosis, it's basically a clot. It's like a DVT of your head, basically. Because we don't think about this. We go like, oh, the arteries in the brain cause a stroke. But the blood's got to drain out of somewhere, right? It's got to drain out of somewhere. So what if that clots off? Oh, if it's the cavernous sinus, then it cooks off cranial nerves 3, 4, and 6, and you have diplopia, cavernous sinus. This is cerebral vein. It's basically a brain DVT, the clot in the cerebral veins, and it can look a lot like a subarachnoid, but the CT is negative and the LP are negative. CT are negative and the LP are negative. Same way we said subarachnoids can have focal findings. Looks like a stroke or a subarachnoid. Looks like a stroke. Subarachnoid is a stroke, the hemorrhage, but the LP is normal. So it's a story like a subarachnoid with a normal scan and LP, and that is the cerebral vein thrombosis, which is where the blood vessels drain out of the brain. And this is a unique test that you don't talk about much, magnetic resonance venography, sort of like a lower extremity duplex of your brain. And now I'm saying here low molecular weight heparin and warfarin because I don't think that you're going to be asked to choose between NOACs and this. The NOACs, rivaroxaban, edoxaban, apixaban, dabigatran, are never really going to ever be studied in something that's an oddity like this because there's no way to study 1,000 cases like this. So they're unlikely to ask you to choose between low molecular weight heparin and warfarin in the same choices. It'll be either these or a NOAC. So if this is not in the choice, then you'll say NOAC, rivaroxaban, apixaban, edoxaban, dabigatran. The same as you would for a DVT. So let's look at the spine disorders. Spinal disorders can seem very confusing to a lot of people, but you don't have to know very much about either of them. You just have to know Conrad Fisher's type of neuroanatomy. Conrad Fisher neuroanatomy goes like this. The posterior part of the cord has position and vibratory sense. Pain fibers cross in the middle. Pain fibers cross in the middle. So anything that rips the middle of the cord gets rid of the pain fibers. So the anterior spinal artery infarct will damage everything except the posterior column. So everything is lost except position and vibratory sense. So you lose most of the motor and most of the sensory sense. And what's left is position and vibratory. This is the opposite of subacute combined degeneration of the cord. Thank you, B12. Thank you, syphilis. Thank you, B12. Thank you, syphilis, subacute combined degeneration. Because in this one, you're going to lose everything except the back of the cord. So you're flaccidly paralyzed below the level of the infarction. And I mean, when you're going to spinal cord injury, you actually can sort of... You can actually simplify it to say, I don't know what's there, give me an MRI, and there's no treatment. Anterior spinal artery infarction, MRI, no treatment. Subacute combined degeneration of the cord, you'll treat the B12 with the syphilis, but generally by the time you've developed them, it's not going to reverse if it's that far along. You lose the deep tendon reflexes because they have to cross, and it's not just crossing in posterior column. Deep tendon reflexes don't cross at the level of the posterior columns. And you become paraplegic and weak and develop spasticity, and you've lost pain and temperature because the only thing left intact is the posterior column. All right. Now, position and vibratory sense. Do they go up the cord on the same side that they enter the body, or does position and vibratory sense cross and go up the opposite side? position and vibratory sense goes up the same side of the cord as which they entered. They go up ipsilaterally. Ipsilaterally. Now, this is the kind of neuroanatomy you're going to need to know. It's very small. All you need to know is that position and vibratory go up the same side at which they entered, and they cross at the level of the spinal cord, midbrain. Pain and temperature. Do they go up the same side at which they entered, or do they cross and go up the contralateral side? Pain and temperature. Pain and temperature cross in the center of the cord, actually, and go up the contralateral side. Pain and temperature cross, position and vibratory sense don't cross. And why this is important is to understand syringomyelia and Brown-Séquard syndrome. What can you do for the infarct? It's infarcted. There's no Chad's Vasc for spinal artery infarction. Subacute combined degeneration of the cord, the easiest one. Loss of position and vibratory sense, the exact opposite of what we had with anterior spinal artery infarction. B12 and syphilis, you'll treat the B12 and syphilis. It's usually too far gone. That's not really your question because you're going to give the B12 and the penicillin anyway. And the exact opposite is everything stays intact. Only position and vibratory sense is lost. Spinal trauma. You get hit in the spine and everything below it doesn't work. So it's like an infarcting the cord below that level, except that for anterior spinal artery infarction, you still have position and vibratory intact. Spinal trauma is weakness and sensory disturbance for everything below the level of the trauma, and how bad it is in proportion to how much trauma that you had. We'd like steroids to work. Do they work? Probably not. Do we like steroids to work? Yeah, we'd like them to work. They just don't. So the sphincter is impairment, and you lose them at the level of the injury, meaning if you get spinal trauma at T6, T8, you'll be hyperreflexic and spastic for everything below T6 or T8 or T10, wherever you get hit. If you get hit in the cord, it is like the cord being severed, so you get upgoing toes. I'm not crazy about the term positive Babinski. What does that mean? Is that a normal? Is that an abnormal? You know, Babinski described the point is, it's better to say extensor plantar reflex, which is meaning abnormal. Normally toes should curl down, mine do, and this would mean toes curl up because you have hyperreflexia at the level of the injury, hyperreflexia below the level of the injury. At the exact level, you lose the reflexes because you've killed that part of the cord. So spasticity, below the level of the injury. Hyperreflexia, below the level of the injury. Upgoing toes at almost every level. What works for treatment spinal trauma? I'd like steroids to work. They don't, but I'd like them to work. Brown-Séquard. Brown-Séquard is described as a lot of things do. Wartime does advance a lot of medical sciences. A lot of techniques taken. Same place we got scuba gear, self-contained underwater breathing apparatus. Scuba was to be able to place bombs underneath Nazi submarines in the harbor in Marseille. Now, scuba gear. The echocardiogram was really invented to be able to find Nazi submarines. The echo and the sonogram. So Brown-Séquard is get stabbed in the back with a knife with a bayonet. Now remember when I said that pain and temperature cross at the level of the cord and go up the other side? So you lose pain and temperature for the contralateral side, and you lose position and vibratory sense for the ipsilateral side. You cut half the cord, or you have a mass compressing half the cord. And your job is to remember just enough neuroanatomy that says pain and temperature cross at the level of the cord and go up the contralateral side. They cross at the level of entry. And position and vibratory go up the same side. They cross the midbrain. So if you have Brown-Séquard, you have ipsilateral position and vibratory sense loss and contralateral pain and temperature loss. Can you make it through life by just going ipsi contra, ipsi contra? Yes. No treatment. No treatment if it's cut. If it's a mass, you can decompress it, but if the fibers are destroyed and dead, nothing will make any difference. Diagnose and adios. If it's cut, there's nothing to do. If you can get rid of a cancer, it might have some benefit if you get rid of it fast. It's like herniating brain. If you don't get that brain decompressed over a couple of hours, nothing's going to bring it back. Syringomyelia is an interesting word. Syrinx is a $5 word for a bubble or a cavity, a syrinx. I don't go to medical school. Yo, dude, I'm not spending $42,000 a year of in-state tuition for medical school, or $62,000 for a private school, to say bubble in my spinal cord. But syringo is a bubble in my spinal cord. Myelia, but wait a second, isn't that also referred to myelofibrosis, bone marrow, myelodysplasia, bone marrow, multiple myeloma, bone marrow, but myelia here is white matter and spine, and yeah. So it's a cavity, a bubble in your cord, in the central canal. Now, does pain and temperature go up the ipsilateral side, or does it cross and go up the contralateral side? Pain and temperature crosses at the level of entry in the cord. So where does it cross? It crosses in the center of the cord. And that's why syringo, a bubble in the center of the cord, rips those fibers, rips the fibers of which it's crossing, and you get bilateral. And because the upper cord, why don't you get this in the lower cord? Because the thoracic cord has more space to it, it's bigger. And so therefore you have the ability to rip across the spinal cord with that bubble, and that's why it goes across both arms in a cape. You know, I'm sure you have capes running around, right? Very Superman, very Batman. And you lose reflexes because it crosses in the center of the cord. So you have muscle atrophy because you are now going to become weak. You have muscle atrophy because it becomes weak. Syringomyelia. Ooh, it's a bubble in the center of the cord. Syringomyelia. Treatment, syringomyelia. It's a bubble in the center of the cord. Syrinx, a $5 word for bubble or cavity. MRI, surgical decompression. MRI, surgically decompress. The most accurate test for spinal cord things in all of them is an MRI, and it depends what the thing is that's happened. If it's a spondylocord from being cut, there's nothing to be done. If it's spondylocord from cancer compression, you can decompress it if it's from cancer compression. And in syringomyelia, you drain the fluid. So things like the spinal cord disorders, they're really hard for people at the first because it's like, but you don't need to learn too much neuroanatomy. Neuroanatomy for step 2 is actually 10 times easier than step 1. You have to start learning all these tracts for step 1 and pathways. You don't need to know any of that. You need to know pain and temperature cross at the cord, go up the other side, and position of vibratory goes up the same side of the cord. Much simpler, isn't it? See you in the next section.